Start. Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from San Hospital, Mumbai. We thank the authorities at San Hospital for allowing us to conduct these classes here, and we also thank Aristo Pharma for an educational grant to facilitate the live webcast of these classes. Today we have two cases. The first case is being presented by Dr. Akif. So we start with the first case.
Good evening, everyone. I'll be starting the case. So, 1 year, 2-month-old boy, first by birth order, born out of non-consanguineous marriage, resident and native of Govandi, Sayyid by community and Muslim by religion, brought by parents with complaints of excessive weight gain since 2 months of age. Patient was apparently alright until 2 months of age when parents started noticing excessive weight gain, about 1 kilos per month. Initially, the mother would feed 8 to 10 times a day, which further increased to 12 to 15 times a day, which is present even to this day. On inquiry, there is also history of excessive crying and agitation if there was any delay in feeds for more than 2 to 3 hours. Mother has exclusively breastfed the child until 5 months of age and semi-appropriate complementary feeds introduced thereafter. The dietary history is elaborated later. The patient was also shown to a private practitioner at 7 months for the same complaints, who advised dietary modifications, to which the parents were fairly compliant. There was no history of formula feeds initially, excessive sweets, bakery products or processed foods, no history of any chronic drug intake, no similar complaints in the family, no visual disturbances, seizures or altered sensorium, no history of dry skin, constipation or lethargy. There was no history of generalized or localized swelling. There was no history of snoring, recurrent nebulization or family history of allergies, no history of dark velvety patches over the skin, no history of recurrent admissions for any infections. No previous admissions. ANC history was also unremarkable. Spontaneous conception at 28 years. 7 USG scans were done and told to be a normal and a well-growing child. Preconception weight was 40 kilos and weight at term was 50 kilos. There was no history of gestational diabetes mellitus, hypothyroidism, hypertension during pregnancy. Birth history, it was a full-term LSCS in view of meconium stained liquor. Birth weight of 2.7 kilos, cried immediately after birth, no NICU stay, and breastfeeding was started within 2 hours of birth, no neonatal jaundice or neonatal seizures, and discharged on day of life 6 with normal vitals. He was immunized till date, and developmentally, under gross motor, he achieved neck holding in 5 months, sitting with support at 8 months. Currently, cruising is present but momentarily and cannot turn from supine to prone or vice versa. Under fine motor, he has mature grasp present. He can speak bisyllables and waves bye-bye at 1 year of age. So there is appropriate development except slight motor delay, probably owing to the excessive weight gain. So this was the dietary history at 7 months and 14 months of age. So as we can see, at 7 months, the mother would, before the dietary modification was advised by the local private practitioner, so mother would feed khichdi and 1 full packet of biscuits per day, along with breastfeeding 12 to 15 times a day. So that amounted to a total calories of 900 and protein of 17 gram per day. The calories were excess and protein was fairly normal. At 14 months of age, after the dietary modifications were advised, the patient now takes 1000 kilocalories as expected, and protein intake is also fine. Socioeconomic and family history: father is a rickshaw driver, earns 15,000 a month, study till 7th standard, and they belong to upper lower class according to modified Kuppaswamy scale.
So, what is your thought process when you got this chief complaint? Excessive weight since 2 months of age. So, how would you proceed in analyzing the complaint?
First of all, we have to see if the weight gain is appropriate or inappropriate. So, for a well-growing child would gain 30 gram per day for the first three months, and so 20 gram for the next 3 months, and so on. So we have to see the weight gain, how is it progressing, also the feeds that are being given to the child, whether it is whether the weight gain is appropriate or not.
Yeah, so appropriate, fine. So now this 30, the rule of 30 grams and all, is for all babies?
It's for term infants, healthy term infants.
Meaning what I'm trying to say is, how will this vary a little, depending on what? So term infant weighing 2 kg, will the same rule apply? Term infant weighing 4 kg, will the same rule apply?
Depending on the birth weight, if it is 2 kgs, I mean low birth weight FGR babies, their weight gain is expected to be a little more.
So which low birth weight babies weight gain is expected to be more, and which low birth weight babies weight gain will not be more?
Babies like small for gestational age, weight will be less only.
Will be?
Less only.
Will remain less. And so who will gain more? So who will gain more than 30? Preterm. So what decides this basically? It is whether it is average for gestational age or no. So preterms will catch up. Who will not catch up? SGAs will catch up or not catch up? So who will not catch up? Which IUGR? Symmetrical IUGR will not catch up, right? So that is the first thing, that it depends on whether it was just a preterm and therefore low birth weight, or a SGA or a symmetrical IUGR. So catch up, if it is happening, it could well be more than 30. Now that 30 is just a guiding figure, assuming that the birth weight is also average. But there is a big range in the birth weight also. So you have 2.5 to 3.5. So somebody who was born at 3.5 will definitely gain more than 30. It will not stick to 30, right? So that is the first thing to understand.
I think what you expect is 750, 800 to even 12 and 1300 per month in the first 3 months. Okay. So imagine 1200 grams per month in the first 3 months will straight away put you to 4.5 kilos more. Okay. And that will not be called abnormal. So weight criteria has a very, very wide thing. But what makes a child not normal, that is important. Weight, of course. Okay. If a child continues to gain weight at the same rate that he was gaining in the first 3 months, in the next 3 months, you start getting a little worried because his weight gain should slowly taper down. That's the first time you will worry. Otherwise, I won't worry if the child has gained 4.5 kilos. Okay. I remember some children who have been kind of obese ultimately, or overweight, if not obesity, have done that initially. Okay. And we don't call it abnormal, though we may warn them to kind of monitor their subsequent weight gain. Okay. So at 2 months of age, the mother thought that he was gaining a kilo per month. So kilo per month is normal. I would expect even 4 kilos in 3 months normal. So at that time, if this was abnormal, how would you have picked up? So what I mean is, the number does not tell you normal or abnormal. Well, if it's out of the range, no question. We saw a 4-year-old child who came with 5 kilos gained in 4 months. Well, that's out of question. But this is within limits. So at that age of 2 months, when the mother said, oh, 2 kilos weight gain, my doctor has said it's too much. Would you start dieting on this child? Would you start investigating on this child? Or would you tell the mother, doesn't matter, he's normal? That's the thing. See, when the story evolves, it becomes little easy for us. But when you start practicing, story comes unevolved. And to me now, it comes evolved. Because they said, पहले डॉक्टर को समझा नहीं समझा नहीं, even I am lucky he did not come to me at that time. Okay. So point is, how would you pick that up? Give a thought. Give a thought. You get the question?
So sir is asking how to pick up abnormality without looking at the number of weight gain, right? That is one. Now look at related question is, there is something in this story which if you can pick up, then tell us what sounds different to you or what is happening.
Excessive cry when was not fed on time.
Yeah, so what does that mean?
Hunger, the child is not able to bear the hunger.
So what does that mean?
Satiety is not attained by the amount of food that has been given.
Okay. Same. Okay. So is that, so even a normal baby would be crying a lot when baby is hungry. So then how do you know this is abnormal?
The requirement was also increasing day by day.
But this was a breastfed baby, no? So you have no quantification of the
But the mother is complaining to the doctor about the hunger. That means it is not a regular hunger.
When the baby is demanding breastfeeds frequently and also probably getting satisfied for a while, but wants it again in a short time, okay, and gaining weight, the question is, why is this baby hungry? And is this hunger for milk, which means energy, or is hunger for water, hydration? Both are coming from breastfeeding. Breast milk gives more of fluids, hydration, and of course the ideal energy. What I am trying to say is that those children who are polyuric abnormally are also going to ask for breastfeeding to satisfy their needs of water, and the water comes along with milk, so energy also comes. So now take it further. You got the thing? Yes. If this child was not getting enough breast milk, he would not have been gaining and he would not have been satisfied. But here is a child who is also not satisfied, but he is gaining weight, which means energy is going up, so it's not inadequate breastfeeding. See how nature is providing this mother enough for that excessive weight gain also. What a nature's way of looking at it, isn't it? So now take it further. How would you know whether this was for wanting more fluids? See, whenever it's a hot summer, you like to take a lot of cold drinks, not for energy. Okay, here is a child, breast milk is also sweet, he is taking sweetened milk. Any thoughts on that? Yes, you were saying something.
Hypoglycemia related.
No, so she's saying that this might mean that baby is getting hypoglycemic and therefore wanting more
Excellent.
feed.
Good idea. Okay, so what she is trying to say is that if energy is not enough, she is wanting more. Okay, but obviously the child is gaining weight well. Okay, so then go further on that. Let's see what is further talked about.
Okay, so at this point, one or two things from the chat our faculty is asking. We talked of catch-up growth. What is catch-down growth? Is there something like catch-down growth?
Yeah, catch-up is you have to catch. Now, if you are coming down also, you will have to catch.
Any thoughts, sir?
So the question is that how much should the deceleration be allowed? We said how much is the maximum allowed. I said if it's gained 1200 grams a month in the first 3 months, I'm not terribly worried. But I will certainly look for the rest of the environment, the genetic pattern, etc. But at that age, it largely depends on nourishment. Okay. at which time I will look what is decelerating. Okay, and how quick is the deceleration. If there is a quick deceleration, gain, but much less gain, then I start wondering, why are you suddenly gaining less? That is cash down.
So you shouldn't be crossing too many centiles. You shouldn't cross two major centiles on your growth chart, right? That is definitely abnormal, whichever way, upward or downward, correct? Now, just to complete this, Rick, in a breastfed baby, what is the shape of the growth curve in the first 4 or 5 months or 6 months? Or what can be the shape of the growth curve in a perfectly breastfed baby?
Can you draw the velocity? Velocity curve in the first 5-6 months.
So first question, is it suppose excellently breastfed baby and the baby started on, let's say, between the 50th and the 75th centile at birth, will this breastfed baby's curve be all along between 50 and 75th centile only till 6 months, or there will be something else?
No, because you haven't seen the growth chart monitoring, we all have seen. That's the only reference. Okay, all well breastfed babies start climbing the centiles in the first 3-4 months. And at which time the mother is very happy. At which time you should tell her that now this is the time he is going to sort of taper it down and then further taper it down. Otherwise she would come at 5-6 months and say, he was much better earlier, doctor says something wrong. That's a normal.
So this is a pattern of breastfed babies. Now, sir asked a different related question. Have you all seen a velocity curve? Velocity growth curve? Can you just in the air draw a diagram and tell us how it looks like?
Yeah.
So you have a straight line down? That's a velocity curve?
First 3 months, 2.5-3 kilos, so put up a tree. But the next 3 months is 1.5 kilos. Okay, so comes down, okay, and then further is further down, and thereafter is further down till 7-8 years. There is a big small hump, and then again comes down, and then adolescence goes up. Right?
So it is not a bell-shaped curve of your Gaussian curve. The limb starts high up only because the velocity of growth intrauterine is very high and first 3 months is very high. So it starts high, goes higher, then the velocity keeps falling and then finally puberty again, right? So the velocity curve is shaped differently.
And it's a big baby. Let's say it's a baby of 3.8. And then the baby is happy, mother is feeding, and the baby is not gaining 1 kilo or 900 grams per month. The baby is gaining weight, and when the baby started at, let's say, 80th percentile, then the baby starts coming down like that. And the mother sees you at 3 months saying that, well, the baby is coming down percentile wise. What started at 80th percent, now it is about 60th. Then how do you go about? Can this be normal? And when it can be normal? So in an adequately fed baby, this particular thing will also depend upon the genetic potential of the baby. This baby intrauterine growth is good, but now it comes down and may settle down somewhere at 50th, 60th, 70th percent, and then the baby will grow. When it is coming down, also history-wise the baby is happy. Baby is not crying excessively. A happy baby, but not gaining as much as he wants, comes to some age at about 3 months or so, they will come and then they grow. So this baby is coming down to her genetic potential, well-fed baby, and then she goes along that potential. So not every time when the baby is coming down, so you should ask the history, how good is the baby, how happy is the baby. Is it a baby crying excessively, telling you that this is inadequately fed, hungry baby, or it's a happy baby, but the weight is coming down for no apparent reason, and then stabilizes at particular percentile.
I think at this age, it's not genetics as much as it's nutrition. Okay. So we don't have to bring in a lot of factors which are contributing to this kind of a thing. So at this time, let me ask you, what makes us develop our appetite, low or high? Okay, that's one question. And there are people who eat less but continue to grow. And there are people who eat a lot, don't gain weight. So why this kind of a difference? Very good.
Metabolic rate.
So one is metabolism. Excellent. So metabolism decides how much you eat, how much you make, and how much energy. That's one. Who decides the appetite? I mean, some of us now at this age, mine probably not, but at your age, you find something palatable, you will overcome the natural barriers and go on eating, next day suffer. That's not so. Physiologically, what makes us decide how much we take, how much when do we stop eating? Is there some sense? The newborn has also sense, no? What is that sense?
Satiety center.
Okay. Yeah, speak, whatever.
Leptin is one.
So there are two hormones coming from up there. Okay, leptin
Ghrelin.
and ghrelin. Okay, lack of leptin, you have no control on your appetite. So you have everywhere like the clotting and bleeding. Nature has given you both. But if there is an imbalance between those two hormones, for varieties of reasons, you can go on eating and add to that your metabolism is also higher, you go on increasing in weight. Okay. So this may not be abnormal. Correct? So if that is so, then at that stage, would you be worried? I remember one of my students who's now a very big neurologist, his father told me that he was 13 kilos at 1 year of age. Now given 2.5 or 3, he had gained 9 to 10 kilos in the first year. Okay. So when he taught us, his father, he said, no, don't just worry about it. So now the question is, when do you start worrying about it?
So you all said one, you'll think of hypoglycemia, then sir said whether we'll think of whether the baby requires a lot of water. So in relation to that, you want to ask any question? Urine, right. Now in urine, what will you ask? In what is your aim?
The frequency, amount, and the color.
What are you trying to drive at? Means in your mind, what are you thinking? Suppose the baby is really wanting lot of breastfeed because baby is feeling thirsty. What are you thinking of?
Dehydration.
So there's no reason for dehydration. There are no losses happening. So what else? Who feels thirsty? So I said there are no losses happening. So who is a obligate loser? You have to have obligate losses. What situation? Diabetes insipidus or renal tubular disorders. Now difference is renal tubular disorders will be a sick baby not wanting to feed all the time. So diabetes insipidus will have a lot of polyuria, no? So there's an obligate loss of urine. So this baby wants to drink.
You wanted to say something. No, I think that's why the history, you could have asked one question. He's asking every 2 hours, what happens if you don't give him feed when he's crying? Can you make him quiet with some other ways? He would say impossible. He would go on crying more and more until he gets a feed, which means he is certainly crying for a feed. When a normal baby is hungry, for a while, even a small infant can be made to look at something, play with him, and kind of tide over another 10-15 minutes. But this baby, if is abnormal, that child cannot be distracted unless a feed is given. So that could have added on to say, because you have said that ask for every 2 to 3 hours. Okay, but what happens if you don't get a feed? That's how we do a water deprivation test for a polyuria. Oh, you deprive water and he gets sick.
So now you just show us your second page ka all the histories, and now after interpreting all that, what are we left with? So quickly run through that.
So no history of formula feeds, excessive sweet or bakery products, processed foods for nutritional obesity.
Okay, stop. So this is a 1 year old, 1 year, 2 month old. So when could all this have started? At what age?
When complementary feeds are introduced, that is at 6 to 7.
So after 6-7 months of age. But in this case, the weight gain started right at 2 months of age, right? Okay, then.
Then no history of any chronic drug intake, example steroids.
Okay.
No similar complaints in the family for familial or monogenic
Right.
causes. Visual disturbances, seizures, or any CNS pathologies. To
Correct. So now how will you make out visual disturbances in a 1 year old child?
Whether the baby was fixing and following, seeing the mother.
So what visual disturbances do you expect in a SOL which leads to obesity? Where is the SOL which leads to obesity?
Hypothalamic.
Hypothalamic. So what visual disturbance will you expect? Huh? Why diplopia? Meaning you're saying false localizing sign and sixth nerve palsy, that, or raised ICP and third nerve palsy? So what I'm trying to say is your thought process is right, but you have to modify your questions to the age of the child. We have always said that your negative history should be modified to the this. So in a 1 year old child, you won't be able to make out about visual disturbances.
If he's
right?
fixing and following light or seeing the mother, does that?
So that talks of fixing and following just tells you that there is vision, as in there is the optic nerve is intact, right? It doesn't talk about visual acuity. So you are looking at two types of disturbances. One is all these nerve palsies, where if at all there will be diplopia which you can't make out. You can make out by the baby being crying a lot or being uneasy or something like that. And second is field defects. But field defects again at 1 year you can't make out.
We said about which hormone, why hypothyroid? Hypothyroid may come with a little better gain, not even obesity as such, but more importantly, he doesn't want to feed. And even then he is getting weight. Okay. But which is a child who possibly gains weight, also eats more? Which hormone?
Yeah, in other words, and the related question is, what is the ICP model of growth? There is one terminology called ICP model of growth. What is that?
ICP means UC or IC? What is this ICP?
Chalo, I and C and P related to childhood, and guessed that.
I for
Infancy,
yeah.
childhood, puberty. So what decides growth in infancy? Growth hormone, no? Nutrition and insulin decides the growth in infancy. Childhood, growth hormone decides growth, and puberty, sex hormones decide the growth, right? So sir is asking which hormone. So insulin comes higher than
And
thyroid.
also in childhood, thyroid.
You see, growth hormone, you pick up height also and weight also. They don't come with an excessive eating. They are growing because they are metabolizing very well, but there is a stimulus to grow. So which other hormone will come with obesity? Adrenal. Okay. Adrenal will come with an obesity. Hypertension, okay.
Yeah, go on.
No history of dry skin, constipation, and lethargy to rule out hypothyroidism. No generalized or localized swelling to rule out lymphangiectasia. No snoring. For the complications, no snoring, recurrent nebulizations, or family history of allergy to rule out OSA and asthma. No velvety or patches over the skin to rule out insulin resistance, and no recurrent infections to rule out as a supporting evidence for leptin deficiency.
Okay. So now, after all this, what are you left with? So what is your thought process?
One of the causes can be genetic,
Okay.
or Nutritional.
So do you think, we discussed hypoglycemia, so do you think this is like a insulin secreting tumor which is making this child high on insulin and this child is wanting a lot of feed? Is it possible with this history? Think and tell us.
A sicker looking child with maybe a seizure or.
Very good. So absence of a seizure rules this out, because while that high insulin baby would be wanting to eat more, but would also have some point where there would be a hypoglycemia because of that too much insulin and not at the same time being fed or whatever. So absolutely clean story without a seizure goes against that. So that is unlikely. Okay? Yeah. So what else? You said genetic, then?
Nutritional could still be a possibility if the feeding is.
So as we said, because it started when the baby was being exclusively breastfed, it is difficult to call it as nutritional, right? Yeah. Anything else, sir?
I think all that we know is that this baby is happy if fed well, though gaining a lot of weight, and this baby has also normal milestones. And therefore, at this point of time, the only presentation is an increasing weight. It does not rule out something coming up later over time, but so far so good, nothing is coming up. So the question is, we did say about the imbalance in hormones, and they all come from the top there. So is this the beginning of any syndromic problem? Okay, we have no idea. But by the time that he is continuously gaining more and more, okay, that he has not shown a slow tapering that we talked about, and he continues not to do so, because as the time goes he should have started tapering. To begin with, we would have given him an allowance, okay, that he is on the other side of the range. But as he continues beyond the year, see, second year is the time when every mother feels the child is thin. Because the first year they gain 6 kilos, and the second year comes down to 2 or 2.5 kilos. So the mother's perception of 6 kilos more at the end of 1 year comes down to only 2 to 2.5 kilos more in the second year. So the weight drops down to 35% or 30% of the first year. But the height drops only to 50%. In the first year you get almost 25 centimeters, and in the second year you get 12 centimeters, 50%. So 50% length gain and down to 30% weight gain, a child starts looking taller and thinner. That's normal. If that does not happen, I would start worrying. But at this stage, I would also like mother's impression of what's his length like, what's his height like. She may not have measured, but I'm sure the doctors must have measured. That will tell us again, and what is typically a nutritional excess of weight gain, weight and height both have gone up. And we have learned from endocrinologists that short and obese, endocrinal, tall and obese, exogenous. So at that point of time, I would have liked some other within limits. Do you think he's gaining height also? And of course, on examination we will know that. So I think that's the way at this point of time.
So, impression: 1 year, 2-month-old boy born out of non-consanguineous marriage with rapid weight gain over 8 months, with polyphagia and mild motor delay, with fully immunized and good complementary diet, is probably a case of 1. Monogenic obesity, 2. nutritional obesity, and 3. Cushing syndrome.
So any points in favor or against Cushing syndrome at this point on history?
Skin manifestations can be
Like?
there. Purple skin or thin skin.
So that is a doctor's observation. Parents may not observe it. What else?
Child will be dull.
Hmm? Moon-like faces.
Like a typical fat distribution pattern.
Yeah, but all those are examination findings. You don't expect it from parents. So, if at all, something clinical that you can think of which is not there here and which takes you little less likely Cushing's. So, what is the other essential part of Cushing's besides weight gain?
Androgens are increased.
Androgens, anything else?
Recurrent infections.
Hypertension, right? Hypertension is essential. And if this baby were to have hypertension, how would you know clinically?
What is the symptom of hypertension at this age?
Encephalopathy when it's an emergency, but otherwise? Irritability, yeah. So irritability could be a symptom, right? So that is, if that is missing, there is irritability, but that is when he is hungry, and then he is again normal types. So that is something which you, and the second thing, carefully if you notice, you showed at some 7 months you showed 10 kg, right? Or 13 kg or something.
At 7 months he was 14 kilos.
14 kg, right? At 7 months. And then at 14 months you have showed 15.8 kg. So would that be possible in a Cushing's? 7 to 14, and already at 7 months is 14 kg, but at 14 months is 15.8 kg, right? So if these values are right, then that is unlikely in Cushing's. So these are the things which is against Cushing's.
And I think if this adrenal problem has started at 2 months of age, you call it either adrenal hyperplasia or adrenal tumor, it would have gone on worsening much quicker. And the child, whenever I've seen few of them, they came with breathlessness due to hypertension. Initially they thought, oh, it was obesity, big tummy, etc. But they had breathlessness coming up. So it would have manifested well. Other thing is the hirsutism. Okay, they will come with hirsutism, and therefore we could have got some clue on the history. Is there some hairs coming up also? Is it an irritability indicating hypertension coming up? Not easy to pick up, I can understand, but this long story puts that a little aside, and I think possibly not that.
Few of our online comments, so some our faculties, one, they've said infant of diabetic mother can have catch down growth soon after birth. Then Dr. Asma has said with polyuria child will not have good weight gain, that we already discussed. Then Dr. Palniraman said what sir just said, that second year if the weight gain continues, then something is wrong. And in Cushing's, height will not be proportionate to weight, which of course parents may or may not pick up, but we will have to pick up.
So examination, the child was active, alert and comfortable. Temperature was normal, heart rate of 130 beats per minute, respiratory rate of 36 cycles per minute, saturation 97. Anthropometry, weight was 15.8 kilos, more than +3 standard deviation. Length 80 centimeter, median to +1 standard deviation. MUAC 20 centimeter, more than +3 standard deviation. Head circumference 50, +2 to +3 standard deviation, and weight for length was more than +3 standard deviation. So he was tall and obese. This was the child. So this was the growth chart that was plotted using the values which the father had recorded. Weight for age. There was a single measure available.
Show the previous growth. What's your comment on that? Comment between 8 months and 12 months, that year's chap. Does it give you some clue?
The dietary modification has had an impact on the weight.
So you can see that that slope which was going up seems to be flattening down. Okay, we would have been happy if it did earlier, but it's doing later. Okay, against a disease. Against any disease. Because he has started flattening. If there was a disease, it would have gone. It may not have gone the same velocity, but certainly, if you see 8 months and 12 months, they are at the same level, maybe a little up and down, but at the same level. Okay, that tells me that there is no disease-like way. Okay.
Then length for
1 second. Just show your this. Okay, this was the length you are showing. No?
this is the weight for each.
Next one. This is the length.
Yes.
Okay. So my question is that we say that tall and obese is exogenous obesity. How tall can this child be? Means the height will go outside, the weight is obviously outside the curves. Will the height be outside the curves or inside the curves? Getting my question? Because I am saying, see, his height is within the curves. His weight was outside. So he is actually short, no? So
he
it's
is asking why there is a disproportionate weight and height. Weight is disproportionately higher, height is high, but proportionately lower. What does that mean? Is he tall and obese, or you call him short and obese?
relatively short and obese.
Relatively. Okay, yeah.
Actually, he's falling between median to +1, so that should be appropriate height. Yeah.
Correct. The point I am making is that when it is nutritional reasons pushing the height up, it will not go beyond 95th centile. This is something which is very important to remember and learn. So it will be in the higher centiles, but it will not be abnormal beyond the 95th centile. Right?
But
And
just another question on this. You have a malnourished child. You start feeding. His length picks up first, then the weight, no? Head circumference always not affected by nutrition. And between weight and height, the nature gives whatever energy you are consuming first to length and then to weight. Okay, weight is the last to catch up. Height is going to catch up before the weight. But here we are saying weight has gone much, but the height has not gone. What is nature doing then? Nature in a malnutrition says weight can come up any time in life, but the length has only limited years, so must catch up. And here is the other way around. In other words, nature knows what is best. Okay. The length is picked up first because the length has a duration. And if you don't continue to get that much of nutrition, or many other factors will come in, of course, but then the height may suffer. So this is another way. That if you had something down the line at 8 months, like you had a weight, you might have seen that it is already coming to close to normal. Okay. So the height velocity was a little lower than the weight velocity. That's the nature's way. Okay. Again, weight can be reduced if it was nutritional. Okay, diet, exercise, within limits, genetic. But the height cannot be reduced once applied. Can the height be reduced any time in life? Why should the height be reduced?
The velocity can reduce, but not the height.
I have lost about 3/4 of an inch because my vertebrae will start collapsing. Okay. I had to change my length of the pants, etc. Okay, and people were wondering, what is this happening? Okay, so, but this is not the area to talk about that. I was just going to tell you that many times as the intervertebral discs start getting degenerated, you also lose height.
And also kyphoscoliosis if the child is
adds to that.
Adolescent girls, the typical posture that they adopt. So if there or any other reason, the upper segment may not be as much as you want.
So Dr. Archana Joshi has asked an important point. Is there any history of taking any Ayurvedic or homeopathic tonics or drugs? Because these sometimes contain steroidal preparations and infants are often given such products.
That would have presented like an adrenal.
Correct, like a steroid.
Yeah.
And Dr. Pramod Kulkarni is asking for STRI, which we are coming to examination. And both Mahesh and Dr. Palni Raman are saying that now it looks like a physiological variation of normal.
So weight for length, as you can see, is more than +3 standard deviation. Head circumference, again more than +3 standard deviation. On head-to-toe examination, there was no...
So he is macrocephalic. Yes, I think by definition it will be. So, will you be worried about it?
So again, what is your common sense approach to this?
Again, the relativity concept comes in. The child is big, so.
So how will you confirm that on this growth chart? That I am, because this parent will ask you, sir, head is large, should I do a CT scan of the head? And you decide based on the growth chart. Come on, think. Very simple answer.
They know it.
Successively monitor the head circumference.
And if it is dash, don't do anything. So if it is what?
I will ask you the other way around. Tell me causes of macrocephaly.
Hydrocephalus.
Okay, hydrocephalus.
Familial big.
Familial. Then just the group, the other big group. Alexander Canavan, whatever. What is the group? What is that group? Neuro? So you will look at the development of the child. If the development is normal, half your worries are done. Look at the familial father-mother head size. If this dot is parallel to the 97th or 95th centile all along, then you're not worried. If your graph is going up of the head circumference, then you are worried, right?
Almost like microcephaly also you will apply the same. He could be a very intelligent person, leave it alone. And autosomal dominant microcephaly is one of those. So look at the father and mother small skull and the child's as well.
So head-to-toe examination was unremarkable except lipomastia. Testes were descended bilaterally. Systemic examination was also within normal limits. So final impression, 1 year 2-month-old boy born out of non-consanguineous marriage with early onset obesity with hyperphagia with a normal systemic examination is probably a case of monogenic obesity or second nutritional obesity.
So you will do a genetic study?
Yes, so we are planning to send one, and some investigations were done from outside. So these were the reports, all within normal limits. This was the weight monitoring chart that the parents were maintaining. And
Okay.
so a few pointers. So,
Yeah, go on.
So when we say obese and overweight and obese, we mean on WHO growth charts, +2 to +3 standard deviation on WHO growth charts is overweight, whereas more than +3 is obese. There are some red flags pointing towards pathological obesity. So early onset obesity, which is rapid weight gain in the first few years of life. So our child had one of these. A short and obese child, a child with hyperphagia, that's again seen in our child. Any dysmorphism, which may point towards Prader-Willi or Bardet-Biedl syndrome. History of any steroid intake, any hypogonadism, or any other associated features like developmental delay, visual disturbances, or behavioral problems. And to remember, most of the obesity is exogenous or primary obesity. So prevention and treatment, again in this child, as we saw on the growth chart, that dietary modification itself led to a change in the weight gain, and this was the. Thank you.
Very good.
So good. So few things practical again. At what age is a child most susceptible to get into obesity? Because as pediatricians, you will have to prevent it at that age.
Toddler age group. Toddler age group.
Okay. So actually at all ages, because you have to monitor the growth chart, but between 5 to 9 is a very critical age. There is something known as adiposity nadir, which comes at 5 years. After that, it again goes up. So when it starts going up, that's the time when all kinds of wrong food can really zoom it up. Okay? So that is the time when you have to, but in general, you have to monitor the growth right from the beginning. And like we said, crossing of 2 centiles. So your 2-year-old who is crossing 2 centiles, you talk to the mother, hundreds of times you will find that they are adding lot of ghee to the preparations which the child is eating, you know, and that's the age when you have to work on this. And the second is that do you ask a 8-year-old, 10-year-old who's overweight to lose weight?
Weight maintenance is the key.
Excellent. So you don't tell them to lose weight but not gain weight, and gradually they walk into their centiles, kind of, right? So that's the other concept.
And I think similar thing can happen the other way around when the child refuses to gain enough weight. Okay. And then you say he is a malnourished child. But what have we learned? The bottom line is difference between sick child, whatever the cause, and no sick child is a happy, playful, active child. Okay. And I see more of those small ones, okay, who start at 3.5 kilos, but then go so slow that at the end of a year, they are just 5 kilos more. And from 3.5, who looks a very chubby baby at birth, is becoming 8.5 at 1 year, and everybody says, go to a better doctor. There is something wrong. But what is easy to go by, he is happy and he has an energy that can make his mother get tired. And then it's easy to ask the mother, who gets tired? Malnourished or well nourished? Okay. And every thin child's mother, I have asked this question, and 100% of them, if my diagnosis is right, he is normal underweight child. The mother has said, oh, by evening I get tired, but this fellow doesn't get tired at all. That's enough to say, don't investigate. This was one of the things. But very well presented.
Yeah.
And
in fact,
you added something at the end. That was very good. I think that's a lesson for subsequent presenters, that he gave us an idea how we could have gone further on that. Okay, but just tell me the last thing. What is the prognosis of this child? How will he be like an adult? He's fine, he's happy, he's normal.
But
What do you think?
Ultimately, there will be some motor delay owing to the weight. And if there is a monogenic obesity, there is no particular treatment except for enzyme replacement, if there is any. The mainstay of treatment is diet modification and physical exercise. So,
But you said he has a nutritional obesity, correct? Now if that is so, then, and he has a good appetite, then let him grow, no? Where is the problem? According to, he's a normal child. Does normal child need any advice on management? Why should he exercise more?
prone to
Why should he
develop
have-
metabolic syndrome in the future. They are more prone to develop metabolic syndrome in the future.
And therefore all that you would have said is that I will monitor that his velocity is dropping down, okay, as expected. He is always at the height, but then still dropping down. If that is happening, is fine. Okay. Of course, he has to be active.
yeah,
There
and
could be
you
other
have to
factors on
inculcate the
top.
right lifestyle in such a patient. So right from early age, encouraging outdoor activities, sports, etc. Food, again careful, not eating high cal and all that has to be done right from this age.
How often would you monitor blood pressure of such children? How often? What would be your answer to that question? We never take blood pressure at all unless it's a cardiac problem or a renal problem. Okay, that's too bad. But what's your idea? At least this is one area where you want to also measure blood pressure besides other parameters, biochemistry. What do you think?
Every hospital visit.
In fact, the American Academy says every child should have a blood pressure monitoring every year. Okay, of course we don't have them coming every year, and even if they come, we have no time to monitor their blood pressure. But I think, and why should we do that? Like growth, we should also monitor blood pressure and chart on a graph whether it is crossing centiles. Why should we do that? Useless, right? Waste of time.
To prevent complications.
Adult
To
systemic
detect and prevent
hypertension starts in children.
complications.
Okay. And if I am at 25th centile, I am going up to 50th. They said, no, you are within limits. Then I am going to 75th, you are still within limits. Then when I go outside my limit at 30, they said, oh, you have an hypertension. Right? So even blood pressure needs to be monitored. Okay, we normally don't do it, but it's a good idea at an adolescent level, at least just check the blood pressure, and if he's already reaching higher, then say, now be careful, you do it every year or something, right? Good, well done.
So Dr. Mahesh Mohite has also complimented you for an excellent presentation. Yeah. And Dr. Palni adds that Prader-Willi can sometimes have failure to thrive in infancy, and then they start getting obese as a toddler age group and hyperphagia. And Dr. Sanjay Hendre has again said the same thing, that in such a patient we need to monitor the type of food and calories intake. Right? Yeah.
Just
Thank
one
you.
small, I had only few children like that, but the intervention with diet is very effective. And one of the things I found effective was change the cereals from cereals to go to fruits, because children like it, and maybe out of 4 meals, 2 meals if they are made to give fruits, they will not gain weight. The weight gain comes down. And another that I found, especially in North Indian origin, in 2 children, even the parents were very tall and fat as babies, and later on they get. So maybe there is an element of genetic, but intervention is successful like in this particular. But sir, initially I thought that it was genetic. The way he was going up and he
but
hungry.
happy child,
But
happy child.
But, and I thought this must be one of the syndromic ones who are
Yeah,
present.
but he would have been little down there, okay. But the other way is that his appetite is large. We said about the hormonal contribution. Then the only way is he should take a low calorie, large volume food instead of a high calorie and small volume food. In a person who is eating only little, he should have a high calorie dense food, and this chap should have a low calorie dense. After all, his appetite is served when the stomach is full. Okay, those hormones, don't worry what you are getting, they must have a full stomach. Okay, then the hormones work. So low calorie, okay, and large volume. That would be the right treatment for it. Good.
Sir,
But
there's
you
a
have wider recognition of your presentation. Well done, well done.
Sir, there's an interesting suggestion and maybe a question. Can high steroids in breast milk do that?
Height?
High steroids, high amount of steroids in breast milk, can that cause something like this?
First thing, why should be there?
If the mother
steroid
is
in
on
breast milk?
steroids.
Okay, that's my first question. Okay, suppose she has any disease with high cortisol thing, she is not going to produce breast milk, she is sick. So I don't think that. Now if she is taking external steroids, again post-pregnancy, what kind of situation is she taking, and how much would that get into the
Correct.
thing?
Yeah.
Every time you give a lactating mother any drug, and you are worried whether it is safe for a breastfed baby, you can consider how you can time the introduction of that drug so that at that level the serum levels are low, the milk levels are further low. So if I have a toxic drug that the mother is taking, I would give her the drug and feed the baby at that time. Half an hour later, her serum levels of the drug are going up. At that time, a fractional increase in the breast milk level. By the time another 3 hours down the line, the next feed comes, all that is diluted and the babies can feed well. So you can manage that, but I don't think that's a problem really.
And of course, we know that Dr. Anjali has added that adding millets to food can also decrease the speed of weight gain. Yeah. Okay, thank you.
Thank you, sir.
So we move on to the second case for today.
Something unusual,
Yeah.
not very common, but very well done. And I think many of these male children come because the penis looks very small, and we all know it's embedded in the fat, and that's a common presentation of an obesity. They're not worried about the weight. They are worried about why penis looks very small.
And that complaint usually comes from the mother.
So the second case today is being presented by Dr. Akshata. You can start.
Good evening, everyone. Case presentation. A 3-month-old male child, first by birth order, born out of non-consanguineous marriage, resident of Trombay, hailing from UP, Muslim by religion, Sheikh by community, bought by mother who is reliable as an informant with complaints of yellowish discoloration of the skin since 1 day, and complaints of multiple episodes of vomiting since 1 day, and lethargy since 1 day. History of presenting illness. Parents noticed that there was yellowish discoloration of eyes and skin since 1 day, which was associated with passing of high colored urine and pale colored stools. There is also complaints of vomiting since 1 day, 4 episodes post feeding, which was non-bilious, non-blood tinged and non-projectile in nature, containing milk.
1 sec. 1 day means 1 day now or at the age of 1 day?
No sir, for a history of for only 1 day.
So 3-month-old baby
3
since yesterday all these complaints.
Or from the age 1 day of life.
Child is currently 3 months of age, and child had only 1 day history of multiple episodes of vomiting, and from one day history of yellowish discoloration of the skin and eyes.
So from yesterday or day before, na? Okay,
yes.
go on.
Then complaints of 2 episodes of loose stools, which is watery in nature and small quantity, which is not associated with blood and non-foul smelling. There is a history of lethargy, which is also for a duration of 1 day. Child was not accepting feeds well, and there is no history of fever, no history of bleeding manifestation, no history of abdominal distension. There is history of passage of infrequent passage of stool, but was passing stool once in every 4 days, and there is no history of petechiae, no history of convulsion, no history of focal neurological deficit. Past history. There is a past history of icterus. There is history of neonatal jaundice present on day of life 4. Child had received phototherapy for a duration of 24 hours, and there is no history of liver disease in the family. In antenatal history, the mother registered pregnancy. Mother has taken iron folic acid supplementation. Totally 5 antenatal scans was done, and no abnormality was detected in the scans, and there is no history of complications during the pregnancy. but there is a history of bleeding per vagina with abdominal pain at 7 months of gestation, and there is a history of early preterm vaginal delivery. In natal history, early preterm delivery, born by vaginal delivery by forceps at 34 weeks of gestation. Birth weight of child was 1.4 kg. Baby cried immediately after birth. There is history of NICU stay in view of neonatal jaundice, for which child has received phototherapy. Child was on O2 by nasal prongs on day of life 14. In view of increased respiratory distress, and child has also received 1 PRC transfusion during the NICU stay, and the investigations were done during this stay. USG skull and USG abdomen showed no significant findings, and ROP screening was done, which showed zone 3 immature findings, and birth vaccines were given. The child was discharged on day of life 35. The child has received birth vaccines. Diet history, the child is on exclusively breastfeed on demand is breastfeed on demand done. Developmental history, in gross motor, the child has not attained neck holding. Fine motor, the child is able to close and open the hands. Social smile is present, and the child recognizes the mother. In language, child is having cooing, and fixation of eyes is also present. Family history, there is no history of congenital or inherited disease in the family. The family belongs to lower social economic class according to modified Kupuswamy classification.
Okay, wait.
Go to the chief complaint.
So what are your thoughts? A 3-month-old baby has come to you with history of high colored urine, pale stools and yellow discoloration of eyes since yesterday. And in addition, there is vomiting, loose motions, and that's about it. And history of lethargy.
Some acute event which probably is involving hepatocellular.
So what kind of acute event? An acute infection?
Probably an acute infection.
Okay, so acute infection meaning hepatotropic viral infection, so viral hepatitis.
Too acute a presentation for hepatotropic viral hepatitis.
So too acute as in all that prodrome and all you expect in an older child. No, this is a newborn, so infections will progress fast. So that's why this has progressed faster. Come on, any other thoughts? Come on. Okay, besides infection, you want to think of anything else? Or it's infection only? Can it be biliary atresia? Extrahepatic obstruction?
Not a well child.
Lethargy going
Lethargic.
against biliary atresia.
Okay. So lethargy could be due to vomiting and loose motions. No, 3-month-old child who's had vomit and loose motions, lost some water, could be lethargic due to that.
First time presenting at 3 months is also little not in favor of biliary atresia.
Any other category you want to discuss? We've discussed infections, we've discussed biliary atresia. We'll talk more about each one, but any other?
Any metabolic disorders? It's such an acute presentation. Um,
So, would metabolic present at 3 months? Should it present earlier, later, or you want to qualify your answer with something? Why has this metabolic presented at this age, if at all?
any underlying sickness like
Very good. So, many times metabolic disorders are unmasked by illnesses. So, the vomiting and loose motions may be some unhygienic feeding or whatever, some illness, and that could have unmasked a metabolic disorder. So, that is a possibility, right?
I think two things. Whenever there is an acute onset problem, we are looking at never an infection. Infection doesn't come acutely in one day. Okay. Take any infection. It mounts up in 24, 48 hours or even longer. So if we believe that this came within 24 hours of onset, then it cannot be infection. Then it can be only of three types. We have done it again and again many times. One is mechanical cause. Trauma, inhaled foreign body, out of question. Okay. Second is a metabolic, what she talked about. And the third is immune. Immune is unlikely at this age. So that leaves us to metabolic. Metabolic what? Metabolic problems do come with vomiting, loose stool maybe, lethargy, yes, jaundice, yes. But it starts moment you start ingesting milk. This child has been ingesting breastfeed for almost 3 months. If this was a severe acute metabolic problem, it could have come up much earlier. And if it was coming up slowly, it would not have come at that age. And what is the story of an acute IEM presentation? The jaundice comes a little later. The first story is a vomiting, hypoglycemia, seizure, drowsiness, unconsciousness, and the jaundice has not even appeared. See, acute hepatic injury does not present with jaundice. Rice syndrome, okay, no jaundice, but hypoglycemia, hyperammonemia, and you present neurologically. So this is not metabolic. This is neither metabolic, nor immune, nor physical, nor infection. We have taken all groups of etiology, and therefore there is something else missing in this child. What is it? In a jaundice where there is a high colored urine and pale stools, which comes first? You have a biliary atresia. Okay. Which comes first? Which comes later? Jaundice comes first. Okay. And after some time, why? Because of when the obstruction increases almost to none, severe obstruction, nothing can pass, pale color stool come up. If this has come up together, parents have missed earlier. The history needs to be checked again. But parents have not observed. You have not faulted. But I would have said that high colored urine and pale colored stool never come together. So, high colored urine and pale colored stool, which one is likely to be missed? Either of the two maybe. But the jaundice could have been easily missed. So the story is not one day, story has to be longer. Okay, now how long we don't know. But we already said that it takes few days, maybe weeks also, before the pale color stool comes. And the gastroenterologist teaches that every time you see a stool which is not pale colored, you have to see the core of the stool. You have to dissect the stool. What does it mean? It takes time. Okay. That means this is going on for a few days, few weeks. Okay. So now you have a chronic story straight off from there. Okay.
Add to that, you should have asked that how is the baby doing in these
Absolutely.
3 months. So how is the baby feeding? Is the baby active, playful? Because ultimately you want to look at your broad categories of biliary tract or hepatocellular, right? So you need to ask about those 3 months. So that is a history. Do you have that history or no? It's okay if you don't.
It's not written, but child was playful during 3 months. It was feeding well also.
Feeding well and growing well. Yeah.
I'll give another angle to all that. There is a story. Yeah. You wanted to say something?
Growing, feeding well, but
Growing, they don't know. Okay.
I'll give you another angle to what we have discussed. Okay. I said it could be weeks or longer, but it could be days also. It could be 1 week story. So let's look at both. Was it 2, 3, 4, 6 weeks story, or was it 1 or 2 weeks story? That would have made a difference. What this child had previously is a preterm, has had a paxil transfusion, must have had antibiotics. Now I'll ask you, which of those can cause hepatotoxicity, hepatic illness, and suddenly appear over 2 weeks at 3 months of age? You get my question? I convince you that this is not acute onset, but could be subacute or chronic. If it's chronic, biliary atresia. Okay. If it is subacute, then what? Then not biliary atresia? Then could it be, must have received antibiotics, broad spectrum, preterm, all that, must have given some infection through bloodstream. Okay. Subacute chronic infection. What are your comments on those possibilities? For example, a gentamicin is commonly used. Okay.
Ceftriaxone is known to cause
cephalosporins are used.
cholestasis.
They are damaging liver. Okay. Slowly the liver is damaged and manifesting subacute illness.
It should not happen after so many days of receiving antibiotics. It would be immediate, very.
Okay, so antibiotics, it should happen either immediately or soon thereafter, so not so many days.
Transfusion induced incubation period. So the question is, what is the incubation period of a transfusion induced infection? Now you will tell me whether that child who received at age 2 weeks or 4 weeks could have a long incubation period and presenting now. So what is the incubation period of transfusion acquired infections?
Generally months. Months.
Many months.
So you are injecting infection into a bloodstream. Okay. So then incubation period is right. What does the bacteriologist do? Put it in a blood agar plate, no? How long it takes? Few days maybe. Okay.
So it cuts down the incubation period drastically.
This is not related to antibiotics or transfusion. Okay. Now I'll give you a third angle. Okay. This child is a preterm. Alright. Pyloric stenosis. Pyloric stenosis present with jaundice, presents with vomiting, and presents with lethargy, hyponatremia, losing. Okay, pyloric stenosis. And pyloric stenosis may present never at birth mostly, rarely also at birth, but presents a little later, no? Oh, this is pyloric stenosis.
Fight. Would be vomiting and it would be post-feed, not immediately post-feed, but it would be related to feeding. It will come with vomiting and no jaundice.
No jaundice. Okay. But it's a long story of, and it doesn't start at 3 months. It would start earlier. And jaundice is not such a prominent thing, and that too conjugated jaundice with your clay-colored stools and all that.
Why do they start, the obstruction is there at birth, why do they start vomiting after 15-20 days? Because the vomiting is largely due to gastritis, due to stagnation. Though there is obstruction, it takes time for the gastritis to develop, and that keeps on. And therefore, it almost never presents at birth, though the mechanical obstruction may be at birth, it presents. And I think the child...
Sir, hold like this.
Child is presented with jaundice because of any sickness. Sickness will come first and jaundice will come afterwards. how can any infection except biliary atresia, which is non-infective condition, in any jaundice, for example, the constitutional symptoms should come first and jaundice is later.
So we need to tease that history very carefully and very accurately, whether it really everything happened in one day or no. That is one. We have some important, interesting suggestions from our online friends. So one, of course, was mechanical, which sir already said. So choledochal cyst, somebody has suggested, to be kept in mind. Now we have discussed the pros and cons. The other thing is toxic ingestion should be considered. So now, how will you react to that? Partly sir has discussed antibiotics and drugs. How will you react to a toxic ingestion causing all this?
The history should be very much preceding, like the toxin ingestion, then followed by all the symptoms. There should not be any that much of a gap between the jaundice onset and the toxin ingestion.
Okay, what else? So toxic ingestion can be known, unknown, lot of issues. Means, for example, let's stretch it. Can this be paracetamol poisoning? So how will you discuss that?
Again, jaundice will come much later. First, there'll be vomiting and other symptoms.
So one is a careful dissection of the sequence of events, but most important is if this clay colored stool is a fact, it rules out all of them, because all these toxins and all will all start with unconjugated or jaundice and then of course all your sequence of events and all that. There is a sir discussed the blood transfusion. There is a suggestion whether this could be hemolysis following the blood transfusion. So what's your thought on that? Again, conjugated, so it rules it out, right? Very good. Then someone has said that preterm baby is unlikely to be delivered via instrumental delivery. What was this instrument? Forceps, acha. Okay, that's just a comment. And then of course someone has said that unless proved otherwise, you have to rule out neonatal cholestasis in all such cases, which we agreed that whatever. Yeah, sorry.
This child had obviously some indirect bilirubin to begin with. Phototherapy was given. Can indirect bilirubin turn into direct bilirubin over time?
So that indirect hyperbilirubinemia should persist, and then there would be, if there is another added component like biliary atresia, then there could be prolonged jaundice, then followed by direct bilirubinemia because of biliary tract obstruction. It's highly unlikely that the child had one day history of indirect like neonatal jaundice, then was all right, and then developed conjugate.
When we learned, there was a fashion that time, maybe it's given up now. It was called inspissated bile syndrome. Okay, when a prolonged hemolytic indirect bilirubinemia starts getting alteration in the bile consistency and starts causing inspissation and obstruction and causes an obstructive jaundice. I think that is given up now. And I just wanted you to know that. But thereafter, when ultrasonography came in, we started looking at a biliary calculi even in infants. And of course, they would come with some crying episodes of no reason, but that could be ascribed to something. And all those colicky pains also have an interval of no pain. So finally, when the child stops crying because you rock, then doctor will say, keep on doing that. There is no other cause. So occasionally I have seen a biliary stones even in an infant. Okay. And few of them that I recall have even resolved by itself. So they must be acquired because of some reason of change in the consistency of the bile, and it got better. But we are talking about all kinds of obstructions in a biliary tract. whereas biliary atresia is just one. Hypoplasia. What about biliary hypoplasia? I talked about inspissated bile, no more considered. We talked about bile calculi. We talked about the choledochal cyst. And now the development of the biliary canal. So, can it be simply something that is developing slowly? And we have said this is chronic. So, why atresia? Atresia is right since birth, right? And notice at 3 months of age. Okay. So, could it be biliary hypoplasia? Which is kind of a smaller part of the obstruction.
It's
right?
a spectrum, no? So intrahepatic paucity of bile ducts, when it is extreme, it is biliary atresia. So can it be the paucity also?
So paucity of bile ducts hardly presents early in life. It takes a long time. It's a mild jaundice going on. There is no pale color stool because some bile is still coming into the duodenum. So it doesn't come with pale color stool, though it is obstructive. And then of course it is a syndromic, so you have a heart problem and so on. So not likely in this child. But whenever you are talking about biliary tract, do consider all kinds of biliary disorders and not just atresia itself.
Can it be enzymopathy? You have two types, conjugated and unconjugated. You have the Krigler-Najjar and no, almost nobody has seen the other one varieties. Can it be enzymopathies? Vomiting is only for one day. Enzymopathy, if it is there, it is one of those which produces conjugated hyperbilirubinemia. They are not unconjugated. That means those Krigler-Najjar, they basically give rise to unconjugated hyperbilirubinemia. They will not come with pale colored stool. So this child has an obstruction, Gilbert or any other thing, they will not come with, they have nothing else but an unexpected presence of jaundice in an otherwise good child. Krigler-Najjar is a different ball game altogether.
Yeah, so rightly so, people have said that anthropology will guide us whether it's acute or chronic. And secondly, it could well be a chronic neonatal hepatitis, torch infection, etc. So we'll look at all that on examination.
Now on this slide, I want you to guess when did the disease start. We said this certainly not one day, but we discussed subacute onset and a chronic onset. Okay. Comment on this chart, this slide, and tell me when did it start. The child is 3 months old, right? Yes.
On examination, child was
Wait. Sir has asked a question.
Crude chart is a good idea to decide ODP. Origin, duration, progress, growth chart can tell us. Where is the origin of this disease?
So do you remember how this child was born? Preterm. How preterm? 34 weeks. And weight at birth? 1.4 kg. So 34 weeks, 1.4 kg. Now interpret this and tell us when do you think?
1.4 has become 2.6. So gain of 1.2 kilogram. How long does it take to gain 1.2 kilogram?
1 month.
Little more than that because there will be first loss of
6 weeks maybe. Good. So now the length.
50 centimeters. So at 34 weeks preterm, we've been told it's a preterm. So what length do you expect? 34 weeks. Little bit less than the birth length of 50. Any other thoughts?
Let me give a clue to it. Okay. We have said that just before birth the growth is faster and then continues to be faster in the first 3 months. Okay. Maybe a little faster earlier or similar. So now what is the similar length improvement? Okay. You have got
In first
50
month, how much do you expect to gain length in a normal baby who's born 50?
So 34 to 39, take 5 weeks. How much is the 5-week length gain? Almost similar to what happens in the postnatal 5 weeks. How much is postnatal 5 weeks gain? You minus that much from 50, you get an idea. So tell me, how much is the first 5 weeks gain in length postnatally?
50 say how much?
4, she said, yes.
Even more.
Fine. Okay, so go back 4. And therefore, he must have started with 45, 46. So now 45, 46 has become 50.
In 3 months.
3 months. Okay. Now tell me, when did this story start, origin?
You got the point? So has the baby gained some length or not gained any length? Gained some length. Gained normal length or less than normal length? Less than expected or normal as much as expected? Less than expected. So if length has already been affected by the disease, less than expected, that means the disease couldn't have started yesterday. So we are sure of that. But the baby has gained some length. So could it have started at birth? If it had started intrauterine, then what would be the gain of weight and height?
See, 4 centimeters we expected in 5 weeks. Now this child is 12 weeks. Okay. And therefore the story must have started at least in first 2-3 weeks or close to birth. Okay. And that's why put down that 3 centimeters a month to maybe 1.5 centimeters a month, and you have got 4.5 centimeters in 3 months. So you started it very close to birth, okay, in the first few weeks of life. That much we knew on this. Okay. And now we know that he is failing to thrive. So now we move from the biliary to this.
We just discussed in the previous case that you said a preterm baby is expected to catch up growth. And this was a preterm baby, right? So to that extent, there is failure to thrive.
On examination, child was lethargic and afebrile. Heart rate was around 110 beats per minute with respiratory rate of 48 cycles per minute. Saturation maintaining 100%. Peripheral pulses were well felt. CRT was less than 3 seconds. Extremities were warm with HGT of 186 milligram per deciliter.
Why 186? Normal?
Quite little.
Huh?
Fine only around.
Sorry?
During like acute stress period, it might have been little more.
Okay. I thought 186 is a little surprising. Okay, go on.
Anthropometry. According to anthropometry, child is having weight of 2.6 kg, which is between -2 to -3 standard deviation. Length of 50 centimeter between 0 and -1 standard deviation. And weight by length less than -3 standard deviation. Head circumference of 34 centimeter, which is between -1 and -2 centimeter. And the child falls into failure to thrive impression, anthropometry information. Then pallor was present and icterus was present. There was no cyanosis, lymphadenopathy or edema. In head to toe examination, head was normal. Then anterior fontanelle was distended and tense. Ear and nose normal. Chest and trunk was normal. Spine and genitals were normal. Abdomen was distended and hypospadias was present. Extremities normal. Systemic examination, per abdomen on inspection, it was distended, which was moving.
The baby is here?
No, sir. Actually,
No.
he is in.
Okay.
He was is discharging for follow-up. He is in. The abdomen was distended, moves uniformly with respiration. Umbilicus is stretched and everted. No visible veins. Flanks not full. Genitals is normal. On palpation, soft, non-tender. Liver of 4 centimeter, which is smooth surface, regular margin. Liver span of 7 centimeter and no shifting dullness. spleen of around 2 cm is palpable, which is soft and rounded. On percussion, tympanic note is present. Auscultation, bowel sounds are present. And CNS wise, the child was lethargic and was responsive to pain. In ABPU scale, we got response to pain. Anterior fontanelle was tense and bulging. Tone was increased in all 4 limbs, and sunsetting of eyes was present. Deep tendon reflexes were brisk in all 4 limbs, and plantar extensor was present. And CVS wise, RS wise, the child was having no significant abnormalities.
Wait, go back. So now after examination, what are your thoughts? What did you add on examination?
There is CNS involvement also. There's hydrocephalus.
Okay. Why hydrocephalus?
There is sunsetting sign. There is anterior fontanelle is tense, sunsetting sign.
And what was the head circumference?
34 centimeter.
34 centimeters.
She had given the, now 34 weaker. What must have been the head circumference? We talked about length and weight, etc. What must be the head circumference? 34 weeks, 34. Okay, 28 weeks, 28. Okay, thereafter it's not much different.
Yeah, head growth is completed almost by that time.
And what was the head circumference?
34.
So now also 34.
Oh,
At
now
3
34.
months.
At discharge, 34. Same. 34 was only on
Huh?
discharge. Same. Head circumference didn't change.
In fact, she said -1 to -2 ST.
So now what? Think.
So
You said-
small skull and a hydrocephalus. Is that a possibility? Small skull.
When do you get a small skull?
Torch infections.
And
Any insult in the initial trimesters.
yeah, so insult in the initial trimester, torch infections, then
Genetic.
Then?
Syndromic. Familial.
anything else? Huh? With raised ICP, small skull with raised ICP. Craniosynostosis. Okay, of course, with hydrocephalus is a little difficult.
The fontanelle is open.
Yes.
Open.
Okay.
Tense
And it's tense.
bulging.
So there is certainly extra space occupation. That much we knew. Now the question is, has this child started with much smaller head circumference intranatally? And now hydrocephalus has made it appear apparently normal for his preterm growth. And therefore, if it's a tense and bulging, there is definitely a raised ICT. The question is it congenital or acquired? Okay. For an acquired, there has to be some reason. What is the reason of acquired hydrocephalus at that age? Meningitis, okay, or a hemorrhage, but there is no story of that kind. So it must be congenital, which means possibly the head circumference was much shorter even earlier than what we are talking about. That's the only explanation I can have for this kind of hydrocephalus. Yes, space occupation. Could it be any tumor? We said space occupation. And common space occupation is a hydrocephalus. But could it be any other tumor? Space occupation. I use the word only because I wanted to bring tumor in. What's your... Come on, give a good thought.
Space occupation wouldn't cause increased ICP.
Tumor is out of question. Tumor would have presented. Okay, now go further. which tumor may cause hydrocephalus and not present as tumor? We are just discussing, not relevant to this case definitely, but because you brought in hydrocephalus, I said congenital or acquired. Now we are saying tumor that presents as hydrocephalus. You have seen that.
The CP angle tumor, like medulloblastoma.
CP angle tumor, that would usually present with multiple cranial nerves and in an older
but you are
child.
Right. That's so in the smaller area, okay, around the cerebellum, you might miss the presentation. Of course, on examination, you will always see that. So keep a note on that, right? Now, could a congenital or acquired? Very likely this must be congenital, because there is no event of an acquired trigger. Therefore, we have a congenital hydrocephalus in a preterm, okay, and that I think brings in a congenital infection straight off onto the point.
There's one suggestion on the net, hydrocephalus ex vacuo. So what is your comment on that?
The
What is
apparent dilatation of the ventricles because of cerebral atrophy. Or
very good. So primarily atrophy, and therefore because there is so much space available, a little dilatation. So can this be that? Means that suggestion has come because the head size is not big, or we thought, array, how come only 34?
Possible?
there
So
wouldn't be raised ICP. in that.
excellent. So there wouldn't be a tense fontanelle.
Absolutely.
Absolutely.
Good.
Subdural hematoma is also to be kept in mind. It is outside the brain and it can just give rise to bulging fontanelle, irritability and vomiting, failure to grow. So anytime when you are thinking of increased hair circumference, keep subdural in mind. There are differences in the head shape in subdural and in hydrocephalus. I think in subdural it's the posterior diameter occipitally which is more, while in hydrocephalus the frontal diameter which is. We'll just keep that. That's easily treatable.
Okay. So what is your differential diagnosis?
Actually, patient was a 3-month-old male child, corrected gestational age of 1 month 2 weeks, presented with lethargy, vomiting, jaundice, case of neonatal cholestasis with acute liver failure with coagulopathy and raised ICP, maybe sepsis induced or because of inborn error of metabolism, we had thought.
Okay.
Then we had done investigation. Starting at presentation,
You haven't told us the cause of it.
She's
So
saying
what's your-
inborn error of metabolism.
Pardon?
She thinks inborn error of metabolism.
sepsis induced or inborn error of metabolism.
Septicemia or inborn error of metabolism.
See, the point is that there is no seizure, so it's certainly nothing to do with hypoglycemia. So, if you are talking about a metabolic disorders, we will have to see which one. Okay, all that we have happened is a coagulopathy has come in. It could have been the cause of that. We said meningitis or hemorrhage. Okay, but in that a liver has failed primarily without a seizure. So then, which kind of an inborn error of metabolism? Or could it be simply we have said that this is coming as a prenatal disease. Now that's not inborn error of metabolism. Okay, we have been discussing prenatal origin of a disease or early, very early.
Early.
And I think therefore we don't know at this point of time certainly that. What about PFIC? We said occurred soon after birth, some maybe 2, 3, 4 weeks. Could it be a PFIC worsening? And you have different types which worsen. Okay, one of them worsens very fast, has come with coagulopathy, failure, lethargy, vomiting, hydrocephalus. So that acute inset must have been a hemorrhage. Okay.
Actually, after the child got admitted into the ward, child had an episode of tightening of upper limb and lower limb. GTCS type of convulsion was there, sir. Then the child sensorium deteriorated. We have to intubate that child and we shifted to PICU. And in there we investigations we had done of CBC and
So these findings of TENS fontanelle and all were after this event or before this event?
Child didn't had any convulsion, but child was having tense and bulging fontanelle.
Okay.
After admission inward, child got all these things, but
Okay.
sensorium was poor from the beginning itself.
I think if we call the origin prenatal, then IEM and rest of them are out. Of course, we can't be too sure on what we have been talking
Yeah.
about the anthropometric measurement, but looks likely to be prenatal. And if so, then we are talking about possibly an infection. Is it a chronic worsening neonatal hepatitis that is going on? Okay.
And we had gotten USG skull of the child, which suggestive of hyperechoic collection involving posterior horn of left ventricle, which is 5 centimeter extending into adjacent brain parenchyma involving left gangliocapsular region, thalamus and parietal lobe. And finding was suggestive of grade 4 intracranial hemorrhage. And after this we got done CT brain of child also, which showed an intraparenchymal hemorrhage with approximately measuring of 3 into 2 into 2.2 centimeter in left gangliocapsular region with surrounding hypotensity suggestive of vasogenic edema, and another subcentimetric intraparenchymal hemorrhage was also noted in the surrounding hypotensity suggestive of vasogenic edema.
So you are saying that this hemorrhage occurred before the seizure, no?
Yes, sir.
Because
But we
on
didn't know
presentation this baby had a TENS fontanelle and all that, right?
Yeah.
So that means this hemorrhage has occurred even before that.
Before only it has occurred.
So
but
there was no clinical event at that time?
no clinical event happened in ward. Before that it didn't happen.
Okay.
And when when we got investigation done, CBC HB was actually of 4.5 gram per deciliter with total counts of 16K and hematocrit of 14.4 and platelet of 2.08 lakh. And after that we had done PRC transfusion on regular basis. Then HB got improved. It didn't drop. And in LFTs, direct bilirubin and total bilirubin and direct bilirubin was raised of 9.1 and 5.1, and liver enzymes of AST and ALT was also raised initially of 164 and 160. Then RFTs were maintained. PTNR was deranged, which was more Vmax was present, and we had given FFP transfusion and vitamin K injection also for that. Then serially the child was observed, and the sensorium of the child also improved, and PTNR also was improved, and liver enzymes also got improved. The child was extubated and was shifted back to ward. And for inborn error of metabolism का part के लिए we had worked up for urine for reducing substances, which showed positive. So we had got done urine for non-reducing substances, which was negative, and blood culture was also of no growth. The child is currently shifted to ward and having good sensorium, accepting breastfeeds well, and now on supplements, vitamin ADE, then on UDCA, and is being discharged for intracranial. For ICT raised ICT part, we had initially treated child with 3% NaCl. Then for neonatal cholestasis के लिए we had put child on rifaximin and vitamin ADEK supplements. Along with that, lactulose was also given to the child. Then during the improvement of the child, we had tapered 3% NaCl and stopped, and we had stopped lactulose also. Now child is on ADE supplements along with that UDCA, and has been discharged and is in follow-up.
So what is the cause of jaundice according to you now?
Sepsis induced.
Sepsis induced.
That jaundice and also that intracranial hemorrhage ka part also sepsis induced only has the sepsis induced is the cause. at last we got.
And that urine, you said, reducing substance.
Yeah, that we had worked for pyruvate kinase deficiency के लिए वर्कअप, नो टायरोसिनेमिया के लिए वर्कअप किए थे. फिर बाद में दैट्स वाई लाइक एंड गैलेक्टोसोमिया वर्क ग्लाइकोजन स्टोरेज डिसऑर्डर्स के लिए भी वर्कअप किए थे, बट वी डिडंट गेट एनी पॉजिटिव रिजल्ट.
Okay.
Has jaundice cleared?
It's clearing, and compared to starting, child has become.
What was the last bilirubin?
Bilirubin.
5.8 and 3.1.
So what is improved is neurological status.
Jaundice.
Okay. But the liver part is not improved. The acute is improved. So acute liver failure has come under control. Neurological improvement has occurred.
Yeah. Yes, sir.
But the liver disease is still on there. Okay. And we are trying to decide the cause of liver disease. The rest of it is all. So sepsis is not necessarily to bring in the discussion, because you have enough reason for a coagulopathy to do all that. Okay, in addition, there could have been sepsis, yes, but sepsis is not the cause of the whole situation.
And I mean, the clinical story has to be a little, maybe in more detail if you give, then maybe. So sepsis means there has to be, as so many pointed out, first there has to be a illness. That illness has to progress rapidly, and then you get your jaundice and everything. So everything happening, infection, sepsis and jaundice, all happening in one day is a little difficult.
And like child is in follow-up for more workup.
Yeah. So what I mean is, sepsis is not very easily acceptable as a cause. There could be an underlying liver disease which is still there, which we have not yet pinpointed. Fine, I think anything else anybody wants
I think, but see, I think you did a good job, Atik, but we want you to do better. You must tell us what has happened finally to these children. Okay, we have to learn. Okay, I am convinced that this is a chronic liver disease. Okay, to me it has started prenatally. If it has started prenatally, I will not bring in IM, I will not bring in any other cause, but something that happened prenatally. And I think the closest is a chronic hepatitis, okay, which ultimately on a follow-up might end up with cirrhosis as well, or even a neonatal hepatitis might after a few months start improving and get a normal liver thereafter. So this shall needs that kind of a follow-up. Okay. Now what acutely happened was a hemorrhage, maybe, yes, sepsis maybe, but the whole cause is certainly not sepsis. After all, this has been going on for a long time, and sepsis would not have that. Lastly, jaundice in sepsis is not a big deal. Sepsis may have jaundice, okay, and the jaundice disappears when sepsis disappears. This jaundice has persisted. So sepsis is not the cause of this liver disease at all, but it's a conjecture. Please let us know. He will come on a follow-up, I am sure. Okay, please follow this up. Okay, because then only we all can learn. Yes, and don't take it for granted that we have not to learn anymore. You might look at me and say, what can you learn at this age? But we have still to learn. Okay, and unless you tell us what has happened, we will not know where we are going wrong, right?
Sir, you will just summarize for Aristo both the cases. Sir, no, sir, today you do it. Sir, today you do it. 2 minutes.
I think the first case was an increase in weight gain, and we were debating whether it's going to be any physiological, nutritional, or pathological. And we came to a reasonable conclusion that this child did go on increasing weight much faster, but thereafter, somewhere between 8 and 12 months, that kind of a fastly growing curve was flattening down, and therefore finally we came to a conclusion that what should have happened at 3-4 months of age that the faster growth should start tapering a little. In this child has happened at 8 months of age. And therefore, we could think at the end that it must be nutritional. Certainly, there were enough pinpointers to begin with, and one of the best pinpointer was that the child was happy, developmentally normal, and therefore, finally we concluded that it must be just a nutritional problem. And we discussed how to monitor this child in future. So that was the first. But it was quite interesting, and it's not common that you see an obesity as a presentation and you just leave it at nutritional. So I'm sure we all have learned that we came to conclusion it's nutritional after a good analysis and almost confirmed it subsequently. But we had always in mind whether there was something else happening, and we discussed many things. But when there was a good height and an excessively good weight, we knew endocrine was not a problem, and which we could discuss even by history itself, and we ruled out any other cause. So that was one. But it was very well presented and something unusual, but yes, it did happen. This was another very well presented child, and it fooled us with an acute presentation. But we could analyze that it cannot be acute, it must be chronic or subacute. And then we came to realize it's more likely chronic, and then we saw the anthropometric measurement. In spite of it being a 34-weeker preterm, we could possibly analyze to the best of our ability and said it's likely the origin was prenatal, but could have been an early postnatal within 2-3 weeks. We were not sure whether it was prenatal or an early postnatal. Then we started discussing infection was out of question. So the question was it any inborn error of metabolism? And we had in mind that if it had started so early, then it would have gone much faster. Whereas it has gone comparatively not so fast. At 2-3 weeks of age, an IEM would have just gone on with vomiting, seizure, unconsciousness, and a jaundice to follow thereafter. So to that extent, that was less likely. And then we also discussed whether there was a possibility of a PFIC worsening very fast. Ultimately, on examination, it was clear that there was a neurological complication of a hydrocephalus. And we said that hydrocephalus was either meningitis or a hemorrhage. And this being a liver disease, hemorrhage was more likely. There was no other episode. Now going back, that acute onset was the parental observation of an hemorrhagic problem coming up. The child started vomiting, became drowsy, and thereafter on examination you found all that. So now we have constructed the whole story of a chronic hepatocyte disease, maybe antenatally started or maybe early postnatally started. If it was early postnatally started, an IEM typically would have presented with jaundice much before that, even neurological manifestation. And to that extent, we have to see whether any progression of that kind is still likely in IEM. Okay, so that was one. And if it was prenatal, then we considered a neonatal hepatitis, which is worsening. And we also said that this child has improved neurologically, but not necessarily by liver-wise, and therefore we need to follow this up, and we need to follow what the liver is going to be like. If this liver starts improving over time, then I have a diagnosis of a prenatal infection, luckily getting better by itself over time. Whereas if it is a postnatal presentation, then it would go on worsening. So I think our follow-up of this child will tell me. My guesswork is it has gone a bit slow in hepatic damage. It came up to light only because of neurological complication. But a liver disease seems to be in a 3-month-old child, at least 2.5 months old, or maybe even more than prenatally. And therefore I call it a slowly worsening liver disease. And if that is so, then infection, neonatal hepatitis is more likely to my mind. But I'm sure a follow-up will tell us, and these doctors from Sion Hospital will tell us whenever they know what the final thing is. I think both of you presented very well, and both interesting cases today. Okay, bring such problems that keep us totally guessing, and that keeps all of us, especially me and some of my other colleagues, that we have yet to be learning medicine and we are equally ignorant. Your ignorance and my ignorance is equal. You are 99.99% ignorant. I am 99.98%. Statistically, not significant difference. Okay, so let's join together to learn all the time. Thank you very much. Thanks for both of you.
So we end the class today here. Thank you very much all our online faculty and other students who are watching. I think we had a lot of new people interacting today online, and that is very good beginning to the new year 2024. We request you to spread the word to all your friends, colleagues, other students to join online, whoever are out of Mumbai, and those who are in Mumbai, if they can come here physically, it will add to the interaction. Once again, we thank Sion Hospital authorities and Aristo Pharma for facilitating this live webcast. We meet once again next Thursday at 6 p.m. Thank you.